So before calling Seth to the stage, I'd just like to make a personal comment. Seth and I have worked together through the years on various committees and initiatives. And Seth, I really like to emphasize that infants and young children can't be activists, right? And I have personally observed you not only being an advocate, but you being an activist for all children everywhere, speaking out. And so thank you for giving a voice to those who don't have a voice. And now, if everyone could please join me in congratulating this year's recipient of the Jimmy and Rosalynn Carter Award, Dr. Seth Berkley.
So thank you, Kathy, for that extra remarks, and really thank you for that amazing video. If I was smart, I wouldn't say anything, because it can only go downhill from here. But of course, I really want to thank the board, Marla, Jeff, the staff of the National Foundation for Infectious Diseases for this singular and important honor, and of course, my dear friend, Bruce Gellin, for this nomination. One of my mentors, Bill Fagey, was a past recipient, and I've had the honor of knowing and working with most of the other recipients. But this award has even more special meaning to me as it's named after Jimmy and Rosalynn Carter. Last night in Atlanta, there was a musical gala in Jimmy's honor ahead of his 100th birthday in just 12 days on October 1st. I cut my teeth in global health working for the Task Force for Child Survival at the Carter Center in Uganda. And just to tell a quick story, Jimmy and Rosalynn came to visit. I went to Nairobi to meet them, and we flew over to Entebbe on their plane. President Carter sat me down across from him and told me to tell him about the immunization system and the AIDS epidemic in Uganda. He looked deeply into my eyes with his deep blue eyes and took no notes. But when we met President Museveni later in the day, President Carter spoke in great technical details to the president about the importance of preventing further spread of HIV, improving vaccine rates, and having absorbed basically every single word of what I said, including the complicated place names, the strategies, the names of the health team, President Museveni and the Minister of Health were flabbergasted. President Carter is amazing, and an amazing individual. He's done so much for the world. It was an incredible experience to get to know him and his family, and my thoughts are with him during these very difficult times. Now, moving to the topic at hand, like many of you in the audience, I started with and still have a love for clinical medicine, but I was drawn to infectious disease epidemiology and the public health to make the maximum difference for the population. And of course, the area that particularly captured me was the prevention of infectious diseases through vaccination. To me, probably the most powerful tool in public health. 50 years ago, less than 5% of the world received the 6 vaccines that comprise the newly formed expanded program on immunization. Today, over 90% of children in the world receive at least one routine dose, and children are routinely vaccinated against 18 diseases. This has contributed to the remarkable greater than 70% reduction in under 5 mortality. The way we have to look at this, we have to attribute this to the amazing collaboration that's occurred through different times, but most recently through the Gavi Alliance, bringing together donors, civil society, vaccine manufacturers, and the core alliance partners of UNICEF, WHO, the World Bank, and the Gates Foundation. But despite the greater than 700 vaccine introductions and more than 1 billion unique children who have been immunized, we are not done. Vaccines need to be universally available. Those left behind, the so-called zero-dose children and families, are critical to reach. 2/3 of these families live below the poverty line, and their family members account for 50% of the remaining child mortality. These individuals are more and more found in urban slums, refugee and displaced persons camps, as well as in isolated rural areas. The zero-dose child is a great indicator of whom we must reach, for if you don't receive vaccines, which is the most widely distributed health intervention, then you likely receive nothing. So any plan for progressive universalism of healthcare should start with those hardest to reach and now easier to identify with this immunization indicator, to build the system of delivery of services and to serve as an early warning for the spread of infectious diseases and epidemics. Of course, we don't have vaccines against all of the important infectious diseases. I spent 15 years working on developing a safe, effective, and accessible HIV vaccine after founding the International AIDS Vaccine Initiative. Although there's been many scientific advances and progress, the goal still eludes us. But we did build substantial scientific and vaccine testing capabilities across the developing world that continue to serve us today. Vaccines against epidemic diseases are critical. And we at Gavi were pleased to put in place an advanced purchase commitment for the Ebola vaccine, such that there would be a market mechanism to put a stockpile in place. But we will need the risk tolerance to stand up financial mechanisms for other low-profit, important epidemic diseases. And I know in this room are many of the companies that will develop those vaccines. We can't expect that to be a charity. In this vein of equity, Richard Hatchett and I knew in January 2020 that if the SARS-CoV-2 virus spread and a successful vaccine was able to be created, we would have equity problems. After all, during the 2009 swine flu pandemic, all of the early doses were bought up by high-income countries, leaving none for the rest of the world. But that did not deter us from trying. We set up COVAX and worked to accelerate vaccine development. It was a remarkable feat that a vaccine was approved 327 days after the genome was published. But I am also so pleased that just 39 days after the first approved vaccination was given in the UK, we had the first vaccinations in a Gavi-eligible country. And we had vaccines ready to go around the world. Due to the delay in WHO pre-qualification, it took an additional 43 days for the first vaccinations to begin in multiple African countries, and 42 days after that, COVAX vaccines had been distributed to 100 countries. Of course, the expected vaccine nationalism, vaccine diplomacy, and manufacturing challenges were as bad or even worse than we had expected. And so, although this was the fastest and largest rollout of vaccines to developing countries ever, there were many delays, stockouts, inadequate supply during early and mid-2021. I wish we could have done better with truly equitable distribution. Despite the production of 11 billion doses of vaccine in 2021, just a little over 1% of the population of the 26 lower-income countries were vaccinated in that year. In the end, we distributed 2 billion doses of COVID-19 vaccines, and the coverage rates in the 92 lowest income countries, where half of the world's population resides, reached 57% coverage versus a global average of 67%, with the COVAX doses saving more than 2.7 million lives. But if we have to be honest, despite just living through the worst pandemic in a century, are we that much better prepared for the next evolutionarily inevitable pandemic? The pandemic accord has been difficult to complete. Funding has dried up. With Mpox, the clade 1b current outbreak, and the FIC seemed to catch us unprepared despite a public health emergency of international concern with the clade 2b strain 2 years ago. I'm pleased that at Gavi we now have a financed first response fund that can immediately buy doses, and we now have experience in facilitating dose donations. But of course, once again,